Hi, thanks for joining us for today's discussion on risk management in a healthcare setting, in particular, how boards think about risk management. Today, I'm joined by Stewart Dowrick, who has over 30 years' experience in the healthcare services sector, including as the Chief Executive of Mid-North Coast Local Health District. He held that position from 2011 to 2024. So it's going to be an excellent discussion. Stewart, thanks for joining us.
So what got me into healthcare? So in the late 80s, my parents, one was a nurse, one was in defence. My brother went into defence and I went into healthcare. And I looked at whether I'd be a physio, nurse, OT, who knows what it could have been. And of all things, I went into management, leadership. The local chief executive of the local health district in that era where I grew up in the 80s in a place called Nowra, took time to speak with me and said, look, if you're going to go into this, here's a pathway. So that's where it started. And I've always had an infatuation about doing good things for good people, and healthcare is one of those industries of doing good things for good people. And I started my career there. So that was the backdrop. And then if I look back, for example, when I was chief executive, I had the great chance to work with a range of university partners. Over 14 years, went from no universities literally in our region to having 4 or 5 there. Before I arrived, our region was only receiving about 80 cents for every $1 under a population funding model. By the time I left, we were actually receiving our equitable share of funding. And what that allowed us to do was go from a couple of thousand, from 2,000 healthcare workers up to 5,000 healthcare workers. So working with clinicians to establish cancer centres in rural New South Wales, building cardiac centres, to see the amount of people that we employed who were Aboriginal grow from 1% of our workforce to 5%, nearly 6%, of our workforce, which was terrific over a long period of time. The things I will never forget is those moments in my career in patient care settings when things have happened and you'll never forget the names of people who might have passed away who we could have done better things for. You remember those stories, you remember the people, you remember the families impacted by that. Things happen in our healthcare system, and those things you'll always remember as tragedies that happen, that things could have been done differently, we could have learned from. Any chief executive in any local health district will have those memories of those events they'll never forget.
What is it that boards really think about when it comes to corporate governance, clinical governance, risk and compliance? What are the main things that they think about?
From my 27 years of experience working with boards, a key issue for boards over that time is really trying to manage that area of uncertainty, because boards don't like surprises. The other part to risk and governance and compliance is how do they ensure that they keep the executive teams accountable as well. Their aim is to make sure that we manage surprises, we are across what we need to be across. They're also learning themselves, and we are also listening from them as well. So I think from my point of view, from a long time, it's actually allowing us to listen to our board and share their understanding of risk as well.
And have you found that those perceptions have changed over that 27 years?
Yes, absolutely. The fundamentals of patient safety, finance, the environment are always core issues, and compliance, but the sophistication around those has dramatically changed. But one area that has, I think, dramatically changed is the area of workforce and how we manage to support our workforce. The other area of risk that has changed dramatically, when I think about when I started in healthcare, we were thinking about things like Year 2K in IT, and now we're talking about artificial intelligence and cybersecurity.
How's that balance with clinical care, clinical safety? Obviously, that is one of the North Stars for health services. How do they balance innovation?
You look at healthcare today and how sophisticated it is. And the area of artificial intelligence and digital and all those things has changed dramatically the area of things like hospital and home, how we care for people in home, how we have the dramatic growth in that service, which we couldn't have done 20 or 30 years ago. So boards have been, and the health sector itself has been trying to work out how we balance innovation, patient safety, quality and funding all together. with AI is just no one actually knows where it's going to go and where it's going to stop. And I guess for us in healthcare, it is a patient safety issue because of the issues around security and privacy and those things. So it's obviously top of mind of healthcare boards and also the executives. How do we harness the best of that, but also control it to a point for the best of the patient?
Now, Stuart, when it comes to clinical safety, clinical governance, how does that align in the board's view with broader corporate governance?
I think many organisations are still trying to get that alignment between broader governance and the patient safety quality aspect. In my time, we often kept them separate, not intentionally, but it was just the way it was. It's very hard to have a totally integrated risk management system that brings everything together. Corporate, clinical, workforce, the whole show. It's really difficult for chief executives, boards, and the industry itself. There are obviously those who can do that really well. Often you think about some of the public health authorities in Australia are quite complex and large. Some of these are massive organisations, 25,000 full-time equivalent staff, $3-4 billion budgets, very big organisations. Hunter New England, Metro North in Brisbane are very big organisations. So bring that all together, it's really hard and complex. And that's where your leadership team's really important. Having a board that feels they're getting the right information. It's not about spreadsheets. It's not just having given me the 1,000-page documents. It's having that insight, but also being able to have that connection to the organisation, which is really important for boards, and especially with the risk. It's what am I not hearing? What am I not hearing from clinical safety quality and good boards? We want to hear about those events that could have been done better or something adverse has happened. How could we have prevented that from occurring? Why did it happen? Listen to the frontline staff, listen to the right people, get the right information and use it as a learning experience. We're not here to punish our people because, again, we are treating thousands, if not millions of people every year in our Australian healthcare system. It's huge, it's massive. Unfortunately, there is fragmentation in our system. We have a wonderful private healthcare system in Australia, we have a wonderful public healthcare system. We have a wonderful primary care system. They're all got different governance models. We have a not-for-profit sector. And you've got the aged care sector and the disability sector. And within our own silos is, unfortunately, silos again there as well. So it's always hard. It's always important to work through that. Having good structures, organisation that brings those groups together, who are all trying to do really well every minute of the day. But it's a challenge. And when you do your risk assessments or your risk management, it's just not as simple as saying that patient is part of that team there. That patient is a part of a broader team who's all contributed to that care in some shape or form. You've come through ED, you've gone to a ward, you might have gone to paediatrics and you've gone to the family care team after the event and you've got the GP after. And maybe something hasn't worked through that process as well as it could have been, or it has worked well. It's absolutely paramount for all boards about how we integrate our care system, but not letting those boundaries, artificial boundaries, be an excuse always. We've got to stop that. And I think that's where boards challenge executives about, well, that was their response. Well, hang on, this wasn't. We've got our lanes to swim in, but sometimes you've got to get outside those lanes and just think a bit more laterally, a bit more about the patient, which most people do. But it's very hard. Patients don't see those lines.
Stuart, I might dive into healthcare more generally and aged care, because you just mentioned you've looked at both of those sectors. Have you noticed any major differences in the way they think about clinical care, corporate governance? Any major differences?
There's a number, but they're also similar. So first of all, they have wonderful people who care for the residents or patients. Everyone I've met in aged care or health care, their focus is on that person in front of them, that's their vocation. They love what they do. When I'm walking around aged care facilities recently and last year, and everyone gives me 8 or 10 out of 10 when I ask them, how do you feel about your job? They just love their job. They love their culture. They love what they do. But an important difference is, my view is the clinical safety aspect of it, because people who go into aged care are towards the end of their life. They're in there for different reasons. Some are there because that's where they want to be, and some for family reasons. Some it may be the best place for them. It's a very difficult decision for families to make. In healthcare, there is, I feel, a far greater sophistication in patient safety, clinical assessment, in saying that the patients and the residents are very different and why they're there. And the workforce issues are very different. You've got the healthcare system is generally one of the most well-trained workforces in the country. 80% of people have a base degree, go on to do other studies, 2, 3, 4 degrees. Very big nursing workforce, big medical, allied health. In aged care, they have wonderful people, but again, nursing's maybe 20% of the workforce and 80% is more in the hotel support, activity, living space, and that's again a different workforce issue. So from a board perspective, just your workforces are very different. The same issues about how you find people, but where they come from is different as well. So they're two standout issues. And again, the compliance issues, one's generally Commonwealth and one's generally state, or unless you're in the private system, which is a combination of public and the states and the Commonwealth as well.
And I guess part of that workforce is that in a hospital setting or primary healthcare setting, that is in a more controlled environment where it is in the hospital compared to aged care, where there may be a lot more services related to people going out into the home. How does that sort of change that risk profile?
I think when the reforms that came about that the Commonwealth introduced for aged care from the 1st of November last year was around quality, safety and fiscal responsibility. There were some of the core aspects to that. Got to remember too, in the healthcare system, we provide a lot of care in the community, but often for a short period of time, unless it's something like palliative care. The benchmark is to have 50% of people receiving their end-of-life palliative care support, hopefully at home, but not many districts achieve that. So a lot of aged care providers are looking at that home care support area, which is the right thing to do, to have them stay at home rather than have to come into the facility when they're not ready for that. And then trying to have that lens of that care that they receive or that support at home, whether it's activities, whether it's wound management, what it could be, what feedback comes back to the aged care provider, what do they report in their care plans, or how they keep that, monitor that, who's actually keeping an eye on that information as well and how it's reported. So yeah, it's a challenge. It's a challenge for boards, and I think the two organisations that I've been supporting in the interim roles are still struggling with that. It's not because they don't understand it, it's just we're just not getting that information, but we're also in our early days of that. So it'd be great to hear from those who are really deep into that, how they provide that information back to boards. But it is vital to do that.
Stewart, you hinted there at digital records and digitisation of medical records. How is that changing in relation to things like cyber risk, privacy management? How are boards thinking about that, and how's that changed over time?
Great question. Has changed dramatically. So, in my former role in the healthcare, our board would always raise about cybersecurity and data privacy and have we got it right. And we know across the country there's been breaches. We've seen that, so it's nothing I'm saying is new to anybody. It's a challenge for boards because, again, in the sense of the resourcing required behind that, it's the education and training of our frontline or all staff involved with data integrity and privacy, whether it's the firewalls that we use or whatever those technical aspects that chief executives don't understand. But from a risk perspective, how do we ensure we have the right guardrails around our data, protecting our information, whether it's healthcare or aged care? You've got very sensitive information. Some of it is interpretive, some of it is just observational, shared by people who are fragile, maybe at the beginning of dementia and those things, and it's a very difficult, challenging time for them. How do we ensure we interpret that quality of information which goes in their care plan, which then formulates how we look after these people? So it's just vital. I mean, we weren't never thinking like this 20 years ago about data privacy, or like we are today. We never had the breaches we had 2 decades ago. Like I said, we talked about year 2K being the biggest thing we had to deal with once upon a time. But we've seen too many issues, and again, I don't think we've got it right, but it's top of mind of most boards that I would think of, who are thinking, how do we ensure we protect our data that's used for the right purposes and reasons, that we are using that information when we need to ethically and appropriately as well. That, if we've got research projects going, and if we've got the right ethics behind the information we're using, because that's their information, it's patient information, it's not mine, it's theirs. We are looking after their data for however long we've got it, because we've got it for a long time. So top of mind for all boards, and it will be forever. I can't see it changing.
How do you think Chief Information Security Officers should communicate cyber risk posture? Have you seen good examples of that in a board meeting?
Well, I've seen great examples of what boards would like around cyber risk maturity. We have the standards that are there, and where do we sit? And what I've seen most healthcare organisations that I've worked with have been sadly at the lower maturity end. But at least it gives you a framework for them to at least crystallise and go, okay, there is a framework that people can use. It doesn't give them insight into just how the background works, but it does give them a framework to come from. So I haven't seen anyone I would think is best practice. I think we've had lots of people write about the need to do more. Every chief executive is talking about it. It's an area that we need to do more on. I know healthcare organisations are continuing looking at it. One of the issues that came up with the digital work that I was supporting in Tasmania was around third party. And who's going to sign that off around security? So it is an issue that you're grappling with. Again, part of that whole discussion is obviously third party risk management or third party organisations who are supporting all the health sector in different ways around cyber AI, and contract management we're probably not the best at, in the public system. We do our best at, but there's also areas in the private world as well. So, and having that assurance that the third party that we're dealing with, their board's got it at their top risk and they're managing as well as we are, and who's going to own that breach when it happens, and who's, you're talking about some very big companies involved with this who. That the legal ramifications of a breach could be quite immense, which hasn't been, I don't think, been tested in the Australian context, but, I'm sure it has been around the world. When I was a chief executive, when we think about risk, we had third-party contracts with lots of other organisations providing services into us elsewhere for other things, private sector coming in who might have suppliers elsewhere, and making sure that are they compliant with whatever they might be. But that's a very different, you can actually see that sometimes. You can actually see whether they're compliant sometimes, but this stuff you can't see. It's a real challenge for organisations now, for boards. Having people on boards who are experts in this space is so super important, and executives, leaders important in this space as well. And obviously having your cyber risks reported all the time with your enterprise risk management system and having that top of mind all the time.
Have you seen good examples of a leader in risk or clinical governance, compliance, bring something really insightful to a board and how it's influenced decisions?
When we went through the natural disasters from October 2019 through to middle of 2021, when you have catastrophic fire events and catastrophic flooding events that no one's ever seen before, and it was a challenge initially, but then we all got it. Were we as ready as we should be? You live through those events, you live through walking through hospitals where there's smoke everywhere, you're working with the disaster teams, you've got people whose homes are being burnt down who are working with you, and you've got people who are losing their homes through flood events. But are we prepared? Because we still have to work 24/7. The hospitals don't shut down. And we had disaster plans in place, but when you had to activate them, and we did. We actually went through a wonderful exercise to actually try to design a system to say, when that button's pressed, what do we need immediately, and what are the escalation points for resourcing? What do we actually shut down? What do we start shutting down to the core? And that was a pretty important piece. Another important piece of work we did was around Close the Gap, Indigenous issues that we all confront in this nation. And in my district, we had a very large Aboriginal population, and it was something that our risk people with our board would continually raise. And we were very lucky. We had a board subcommittee around Close the Gap, but it was continually raised through our risk team about the need to do more. I never saw the end of what good looks like. All I know is we were making good progress on things around employment, around care, around making sure we can improve access and treatment of people who were Aboriginal. Two examples of where we used information really wisely to make good decisions around immunisation in 2021-22. But in 2020, when we didn't have information and the nation was together, because there were so many unknowns, we were trying to work together around surgery as a group, as a nation. I can't imagine what the ministers would have been going through. But the pressure locally around things like elective surgery, and should it be cancelled, not cancelled. And I've got to say, I was very challenged by my board because, as I mentioned at the time, even without any data, we could see what was happening around the world with COVID because we were not immunised against it. We know at that time countries like Italy and the US, around 10 to 15% of health people who were dying of COVID were healthcare workers. So you get that angle, but you get the nation's trying to coordinate itself. So all I know is that when the board raised it, it was very challenging for me to say we have to continue on in accordance with the state and national directive. Coincidentally, that only a few days later, the whole country made a decision to cease it on a particular day, and we did that. But we had clinicians without data going, it's okay to go for, they thought it was okay, others didn't. That's okay, we just didn't know. Then you fast forward to 21, 22 with immunisation. We were able to locally get really good granular data about how the immunisation program was going, and therefore internally when vaccines were quite scarce, the nation was actually getting rationed in some respects. Rationed because the world was. It wasn't just Australia, it wasn't New South Wales, it wasn't Mid-North Coast or Campbelltown, it was just the way it was. But we had really good information to go. We knew how people were responding to the vaccine programs. We were able to get very good data that showed how the population was increasing its vaccine rate. So when we needed to intervene with our vaccine program, we could actually be very targeted. That increased in certain pockets of populations their vaccine rates. So we had some communities who were up to 80, 90% quite quickly. They were getting there very quickly without any influence at all, but other pockets didn't. So we needed to use, because we had the Commonwealth program and the state program. So the Commonwealth program was generally through the general practitioners or primary care, and we had our state program, which we opened up big vaccine clinics. So when we did that, either mobile or otherwise, we could target it to those populations who we knew just needed some more support. But we used the information we had very granularly to get down to communities of just 100 people to communities of 50,000 people. So we just used that in a granular way, and it was very effective. Using risk at the time with our board, which was great, was we had very specific risk reports around immunisation. That was very targeted, but we were collecting information from the primary health network and aged care providers and others to go, how are we progressing? So it was very targeted. In some respects, there was a granularity behind it all, but we then rolled it up appropriately to the board and said, against these metrics and targets, this is how so it was actually using information very wisely, very specific, very targeted, but you had all the agencies working together to give you that information. Whereas in other periods, sadly, the walls go up, the barriers go up, and we have difficulties getting information. So again, it's one of those moments I'll never see again in my lifetime, but you see where people can work well.
So in those situations, Stewart, what did good risk reporting look like?
I'll start with the Close the Gap one first. We created, I guess, one of the very unique reporting models. We actually created a great report card. We had realistic targets to achieve, but we actually ensured that the board had a very succinct and smart report to go, are we making progress internally against our peers and others? But we had very clear targets, very clear monitoring. Twice a year, the board, we would have a full session of the board about going through our Close the Gap reports. So that's one. But the other part about what risk looks like and where boards get great information was, you look at areas like ED, emergency management departments. Having systems in place that allow frontline clinicians to come and talk to them. So you've got the executive side, hopefully you've got the ED teams, and just giving them the chance to speak freely to the board around, and in a sense of a model, it's more of a model of observation, discussion, reports. That's the key to this. You've got the spreadsheets, but you need what's the numbers and what's the story, and then you've got boards asking more questions of executives and the chief executive to say, okay, we need to address these questions better. And is our risk framework adequate enough to pick up the nuances that the spreadsheets and other things don't tell us? The sad thing about risk is we see sometimes what disappointed me in my time was when the biggest risk issue you had in your local health district was an elevator in one hospital. Now you knew your systems were failing. You knew straight away. So that was a red flag to go, hang on guys, we've got this, we haven't got the right data set, we haven't got the right IT systems to help us collect that information. That was a true story. It came up that I said, is it truly our biggest issue is an elevator at one hospital, guys? If that's the case, then I can resign and retire happily and leave forever health. But it was just we did not have the adequate systems in place. So having a really better information system and having the awareness that people know how to escalate and what is a true risk. What are the risk strategies? Because risk is a part of what we do. If you understand your risks, you can actually improve your organisation, you can add value to the place. It's always going to be there. In healthcare, aged care, disabilities, it's always going to be there.
Those teams, they do want better systems, I'm sure. So what messages could they deliver to boards if they're looking to invest in better systems, better tools, better ways to manage and report that data up to the board? Are there some key messages they should be thinking about?
Often it's looking at the patient safety side of it, but it's also the value. Why? What is the benefit here? It's not a competition of resourcing, and that, unfortunately, this risk is sometimes seen that way, and a lot of chief executives would say that's unfortunate what people see it. But a key message is, keep it simple, but what is the benefit, but what is the risk? Board members don't always understand the risk. You've got to remember, you've got people who aren't clinicians, but they understand poor outcomes. So it's, this intervention, this innovation will allow us to reduce this from a fall rate of 18% to a fall rate of 2%. That's going to make sense to anyone in any sector. Now, unplanned surgical delays or delays in surgery impact the patient. They're the ones who anxious, anxiety, listen, we have to delay it for many reasons happen. So how do we improve? And that improves care, improves their outcome, improves their relationship with the family. So it's just that benefit and that value. We're not great at defining value. It's not always about dollars and cents. It's about the benefit to the family, the patient's experience, their well-being, their recuperation after a surgery. We've seen massive changes in that over the last 20 years in orthopaedic surgery. We're doing knee procedures now in a day, same-day knee procedures. You wouldn't have thought about that 10, 20 years ago. Now we are. And they're managing risk along the way.
You mentioned some metrics there, Stewart, and some of those are driven by standards around how some of those things need to be reported. But do you see them being something that is done independently and maybe not connected to other risk information that the organisations might have?
Oh yeah, you do see that. You do see probably more in the non-hospital setting. It's like when we were doing work to expand our virtual care services. You sort of had to sort of make up your own value-based indicators, because there, your satisfaction rates, are we delivering the right care? It was actually a new area of, how do you provide, and then how do you report that risk to the board? Like, e.g., we've thousands of people being treated by care in the community or our virtual care services, but no adverse events. But adverse events would generally focus on the acute hospital setting. But again, I'm sure all organisations now with their virtual care teams are finding metrics back to the board to make sure, how safe is it, the value it's delivering, no outcome. But we had to design in the early days a lot of that ourselves, but that's changing too. I mean, industries evolve and develop and morph over time about what standards they want to set.
Stewart, you've mentioned many disparate teams, disparate bits of data, processes that all seem to be a little bit siloed. How important is it to bring all of those components together, and how would you go about doing that?
I never got to the holy grail when I was in my role, but I haven't seen it yet either. 25, 26 years ago when we started the risk journey, we called it the red rocks, or the top red rocks, were the top 20, and it was, a Word document, and everything in red was the magic colour. And I think what changed the thinking of the board, as soon as we purchased a colour photocopier for the first time, and people went, the different shades of grey is actually red, yellow, green. It's actually, but it was only in Word document. And then after that, I worked in an organisation where our risks were like 146 sitting on a spreadsheet, and the executive team would go through those. Where do those 146 come from? And we were investing in better integrated systems, but it is the holy grail, how to bring it all together, the whole enterprise together. And if we're rolling out the new electronic patient digital record, single patient digital record in New South Wales. It'd be great to have that linked to an enterprise risk system that flag different parts of that to the risk system, which you think would be natural to do. Now, I haven't been a part of the New South Wales implementation, but it'd be interesting to know whether that system does link to another risk management system, that it goes all the way to the chief executive, that if you are the chief executive on any one day, you should be able to press a button and go, guess what? These 10 things happen today, we need to get on top of those straight away. Do we have those yet? I don't think so. I think people are still using spreadsheets and other things to keep things together. It's not integrated, and it needs to be natural because the frontline care workers are so busy on what they're doing. We need a system that generates that, whether it's, and how that comes out of the system, I don't know. I don't know the answer to that, but people do need that, and it's, it's the holy grail.
How important is data provenance and knowing, who has created data, who has edited data? How important is that so that boards know that they're getting really good, trustworthy information? The
trustworthiness of information. So obviously boards have to trust what they're presenting is the correct data, but we have healthcare, and when I was working in Tasmania is no different, but also in North Coast and New South Wales, hundreds of systems. And then on top of that, there's people running their own little spreadsheets and other bibs and bobs. So it's not good. We've got to find a way of consolidating all those systems into just what we need. Now, some of those systems have been developed with the Commonwealth in mind, some of the states and the PHN. Some have been designed because they just want to design their own thing. But occasionally you have seen where that's been maybe not as correct. Waiting list management, for example, was the information in that system correct or not? Now that's a risk for an organisation from a performance point of view, but also for the patients. People are given a date to be treated within the national standards in 30, 90 or 365 days, and have those dates or times being manipulated and the trustworthiness of what goes in there. But you do see some of that. In the other area of providence, and occasionally you see it, is in the area of financial management for a board. Are our books correct? I've been involved with cases where someone may have passed away 12 months ago when the system still thinks they're still in the system. Now that's a serious issue. Is the risk or the governance around that as strong as it could be? I'd probably say it needs work to be done.
Stewart, boards need to ingest a lot of information. How does a chief risk officer stand out? What information do they need to provide in that kind of report that has boards pay attention?
What boards don't want to see is inaccurate risk reporting. They don't want to see poor insight or poor judgment or poor commentary, which I've seen. As a chief executive, that's a real challenge when something gets presented and you go, that's just not correct. So for them, it's making sure they do their homework and are clearly articulating what is the risk and what are we trying to achieve. Now, a good risk officer, risk safety officer, needs to find space with the leadership group or the CE to make sure there is an alignment there, because there's nothing worse than going to the board and that report's just is not aligned to the CE. There has to be some alignment, but also some independence. And it's also that insightfulness. It's what's the story behind this? It's just not a number. This has been researched and this is the problem, and we've done that work, we've spoken to the right people, and we've really clarified that, because some people don't always get what's the risk we're trying to define. But it's also not that hard either. It's not that hard. It's just trying to get that messaging right. Not too much. We don't want too much more paperwork. How people present risk, I've seen some clever ways of doing that. The new generation of people using whatever software system can do some great things. But also what I find, people don't use the software they've got. So going to products that have good reporting, just let them just own that reporting. Don't create your own reporting format, use theirs. And I've seen some wonderful products out there that do it really, really well. So, but again, as a chief executive, again, my lessons reporting to boards about risk. I mean, you might give a 40-pager and they just gloss over it and go, blah, blah. It just didn't resonate with me. Can we get what are the core risks, but what's the insights behind those? Why is this here? So, yeah, and mindful that on most boards should have hopefully about a third of people who are clinicians, a third who are consumers, and a third who are subject matter experts, and you're dealing with people who don't have the health lingo, because the problem with risk managers, is getting away from the lingo. Try to just speak plainly, because again, the board is made up of people from the community who aren't in our world of healthcare or aged care or disabilities. We live in our lingo and we need to sensitise that to our audience.
What do you see evolving or coming along the horizon?
Some of these aren't coming along the horizon because they're already in front of us. Obviously workforce. So how we find the next couple of 100,000 people we're going to need to treat our population in the next 5 to 10, 15 years, plus replace the ageing workforce. Where do we find those people? How do we educate? How do we train those people? How do we keep them? How do we retain them? How do we make them feel valued, given that the generation today sees work very different to what we saw 2 generations ago or 3 generations ago? An issue that I see emerging is the area for boards, is the area of leadership and where's the future leaders? And they're there, but how do we keep growing them? How do we keep allowing them, supporting them as they come through the system? Health has been my bread and butter for nearly 4 decades. It's a very tough industry. It's very difficult. You know, you're a major employer. You're on call 24/7 a day. Your site managers, general managers do tough gigs. Your directors of nursing, your medical staff, your nursing. It's a hard role. So where do you find those future leaders who are prepared to make that, or what does leadership in the future look like? You know, that listening more, you know, how do we empower people more? And again, clinically, it's just how do we stay on top of the advancements that are occurring? We're doing things that we never did before, and it's terrific, but how do we stay on top of that as a board from a governance point of view? Don't stymie innovation, make sure that, you know, we keep sponsoring research, you know, keep that go along, because that helps us be innovative. So they're just things I think about the future and the risk around research is things like funding.
And are there any changes that need to be made either in broader corporate governance and the way boards are run, or the way that the executive teams need to manage some of these evolving risks?
Yeah, I think I'd love to see, really, given the integration issues or the silo issues which aren't going to change a great deal, I think some good organisations are sort of, you know, having joint board meetings with their primary health networks, or in rural areas with Aboriginal medical services. And how do those organisations bring their risks together and share and is there a commonality in those risks and share that information? You know, when I was in Mid-North Case, we used to bring the Aboriginal medical services together to talk about our top couple of risks each, and often that was very similar. So are we all on the same page, and can we help each other? I think those better organisations, those more mature governance groups, are finding others who they work closely with, and how do we integrate across sectors our risks together to say, yes, that makes sense. But it's important to me, I've unfortunately been involved with too many exercises with agencies outside of health because it's just their priority. I've got to get involved with it. And I go, well, I get it, but what are we trying to address? What's the problem we're trying to solve? We have people who are really good at admiring a problem, but not actually trying to solve a problem. So it's how do you make a difference? And the other thing here about all this is just delivering outcomes. How do we say in 5 or 10 years, which, you know, this is what we achieved? And unfortunately, I think there's some of that. There's some good places that show that. And I think other places don't show that. And I think we've got to find a way of this work has led to this. Or if it hasn't, it's okay. We did our best for good reasons. That's okay from a risk point of view.
What is it that those leaders really need to succeed?
For leaders today, and there's so many great people out there who do this already, and what they do really well is they get that pitch right, that they know their business. And they know their business because they've been talking to their healthcare workers or their aged care workers. And they can talk with stories and narratives that actually give them insight into what they're trying to get. So actually knowing your business, knowing your frontline care workers, knowing your backroom workers as well. They've got great people. We forget about those who prop up the frontline guys, you know, and the stories they've got to share with us. But it's getting that information set and having that integrated. And that's where I think the future leaders, I can see it happening now, will want a fully integrated system. They will want to bring everything together into one place that helps them make better decisions about resourcing, because a lot of their risk is about how are we going to resource areas differently, because everyone's trying to get a piece of the pie. So it's using that information, bring it together better and getting that pitch right.
Stewart, thank you so much for your time today. It's been great to hear your deep perspectives in this healthcare setting.
Thank you for the opportunity. It's been terrific. I've had a wonderful career. I've worked with some wonderful, wonderful people through my whole life, and it's just been great to share some of those moments today, and it's been great to talk to yourself, Michael. So thank you very much.